Welcome everyone to the introductory material to our Wheeled Mobility and Seating Telehealth Certificate. My name is Richard Schein and I'm joined with.
My name is Andi Saptono.
And we are both from the University of Pittsburgh. And so within this module, our learning objectives are that participants will be able to define what is telehealth, identify two drivers of telehealth, along with identifying literature that provides the history of telehealth applications. So really the first thing that we need to talk about are terms and definitions. One that will be interchanged throughout the modules is that you're going to hear the terms telehealth, telemedicine, and telerehabilitation over and over again. So what we want to do is just provide a basic overview that telehealth is sort of the umbrella term related to telemedicine and telerehabilitation, which are more specific applications and services that incorporate information and technology into the actual service that is being provided.
Right. And you can see just by the definition, it always hits that information and communication technology piece and the service related to that. So what are the drivers? Rich mentioned that we need to identify two at least, right? And there are tons of them. We see clinician shortage. We see rural and urban underserved that have no access to the services, more specific, especially when we're talking about wheelchair prescription, right? There's not many places that people can access that, so they have to travel. And that produces this increase in travel time, cost, and hardship. And with the social and demographic change, the aging populations, this becomes more and more important for us to be able to build a bridge, build a connection, build a platform for them to be able to access the service. And with the rapid development of technology, 5G is coming. This becomes now more of a reality rather than just a dream.
So in terms of the evidence, although research in telehealth is still really developing, we can point to two systematic reviews, which are basically a literature source that puts together specific related applications of research to the telehealth experience. And what we found out in the evidence is that it allows for increased communication. It also allows for improved health outcomes, especially with longer duration of the actual intervention. We're also seeing that there's been reduced utilization and cost. And we talk about scalability to larger populations. Really what the literature is identifying is that the sample sizes have been very small in terms of the sample. And so what we want to do is support larger scale interventions and applications related to telehealth initiatives.
So benefits. It's always important to start by thinking about what can we gain, right, from this approach. Both of us have been in this field for a very, very long time. And we've seen this not only as our own experience, but from others as well. People are reporting improved access to information. They can connect easily. Think about during the pandemic where we cannot move around and we have telehealth and we are able to connect with our clinician. That is the improvement into the access to information. Provision of care not previously deliverable. It is not in our practice, for example, to deliver the care at home. But with telehealth, that becomes possible because now we have the channel to do that. We see improvement into the access to the service. We see professional education. Rich has been using telehealth as a part of mentorship program, education program. And we see a lot of reduction in readmission because we are able to prevent things, improve knowledge, and reduce our feeling of professional isolation. And the drawbacks.
When you have positives, we also have to look at what we can be doing better as a group. So not necessarily drawbacks or negatives. These are just things and applications that we need to do a little bit better at in terms of incorporating them into the actual service itself. So what we've seen is a compromised relationship between the health professional and the patient. So this kind of depersonalization, which comes together with any kind of virtual encounter. We've seen issues of the quality of the clinical information. So really the data informatics piece of it, that big data of exchange. We've also seen a really major organizational changes. Obviously, as we talk more about what's going on with the public health emergency that is currently happening, that we've seen a huge shift in how you're going to be delivering a specific telehealth application. We've also seen where there are specific situations where in person, maybe better utilized or more appropriate than doing it via telehealth. And the last bullet here is the level of comfort with technology. Anything time that you're incorporating something new, it takes time and change of culture a little bit and adopting how the technology is going to be personal and add to your comfort level with it as well.
So what are the telerehabilitation clinical applications that we have seen so far? We see consultation. That's the largest use of telehealth, telerehabilitation, telemedicine is for consultation. In our field, we use it to consult between the clinical rehabilitation engineers or somebody that's more on the ground kind of and connecting with the experts. We see used to provide a provision of assistive technology, connecting physicians and nurses. Let's say they can use camera to monitor pressure sore, making sure that it does not develop into something worse. We see virtual reality being used as part of training, remote rehabilitations, management, and teleconsultation, as well as more of a specialized clinical groups, clinical use of video conferencing. So we welcome everyone to continue to our next module, which is the current practice and key topics. Thank you very much, and looking forward to joining everyone again.
Thank you again.